Minnesota Senate Health, Human Services, Finance, and Policy Committee for today, Wednesday, February 17th. For the record, members, we do have a quorum. We'll begin today with Senate File 753. Senator Abeler, please move your bill and proceed.
Thank you, Madam Chair. This is a bill that's just pretty much common sense. I'd like to move Senate File 753, and it's going to be heading off to Commerce, which I think will be a wonderful experience for everybody. And I have a testifier, and then after that, I have an amendment I'd like to discuss. So this has to do with credentialing, provider credentialing, which seems like an amazing idea that, we have well-credentialed providers. And actually, as a person who's credentialed and met many credentialed providers, pretty much comes down to the fact that you're not a felon. And so there's a great, and I'm only exaggerating a little bit, are you in good standing? Do you have a license? And there's all this discussion about what difference it makes. And we can discuss that another time. But in the process, sometimes they can get dragged out very long for no particularly good reason. And I want to thank the health plans for working with the advocates for this bill, MGMA, the Minnesota Medical Management Group, that's what I meant to say, and others. And so I know you have a big discussion coming on the next bill. So just to be brief, I'll turn it over to my testifier, and then we'll talk about my amendment. Thank you, Madam Chair.
Welcome to the committee, Ms. Reinhardt. Please state your name, your organization, and proceed with your testimony.
Thank you, Madam Chair and members of the committee. My name is Brenda Reinhardt. I am the business office manager at Vitreoretinal Surgery. We have 7 offices here in the state of Minnesota. In addition, I am also the Minnesota MGMA Payer Relations Committee Chair. I would like to thank Senator Abeler today for being chief author of this bill. In addition, I'd also like to thank Senator Klein, Senator Draheim, and Senator Marty for co-authoring this bill. Today, I would like to give you a brief outline of the definition and credentialing process, the lack of transparency in the current process, how this affects patient care, the engagement and agreement with the Council of Health Plans, and how the process change will positively impact both the patient and the providers. Provider credentialing is the process health plans use to evaluate a healthcare provider's education, training, residency, licenses, and certification in order for that healthcare provider to provide healthcare services to patients at clinics and facilities and being reimbursed by the payer. Payer contracts generally do not allow healthcare providers to practice medicine or see patients while they await the credentialing process. Currently, the process of credentialing a provider varies between health plans and takes 60, 90, 120 days or longer to complete the process. Each payer does this internally and with varying requirements and timeline. This affects a patient's care as they cannot see the provider during the credentialing time and must either wait until the process is complete or find a different provider. This is also an administrative burden to healthcare providers and clinics because of the varying processes and lengthy timelines as they have to track status with each payer and cannot schedule until the provider is approved and an effective date is given. The result is that there can be multiple effective dates among payers and can be a scheduling headache for both the clinic and the patient. In addition to varied processes and timelines across payers, there's little transparency in the process. It varies from payer to payer, and in fact, in our fact gathering, issues were found across most commercial payers. Some examples include the date requested of participation will not be confirmed up front in the process, which means a clinic does not know when the provider can start to see patients. Also, if the requested date is given, it is typically confirmed well after the effective date. Recently, a clinic received a confirmation of December 1, 2020 effective date. However, they did not receive written notification until January 22nd, 2021, despite many status update requests during the application timeline. This application was originally submitted on October 1st, 8 weeks before the requested start date. The actual turnaround time was just under 4 months. How is this affecting the clinics? It's impactful because clinics cannot start to schedule patients until the effective participation date is known. Payer contracts do not allow patients to be seen until the date is received in writing. This is extremely problematic when a group has a surgeon ready to start call or regular call at a hospital. It is ironic when the hospital has completed their credentialing and approved privileges, allowing the provider to see patients at the hospital. Now the wait is for approval from each payer. If the provider starts to see patients at the hospital before this time, not only will they potentially be in violation of the payer contract, but the payer will not be reimbursed for the emergency services provided. Communication with payers during this process. Oftentimes, only a department email address is provided with no ability to reach a live person or answer questions or resolve issues. Email requests for status updates often go unanswered. Oftentimes, the payers are directed to the web portal to check status of the applications. Unfortunately, most of the portals do not actually update status until the process is completed. This direction is not helpful. Oftentimes, an email answer from the payer is to watch for an email confirmation of the effective date or wait for a letter to be sent in the mail. Again, no opportunity to ask when this may be expected. Payers state turnaround frame times are stated frame times are not adhered to. For example, they may state the process takes 60 days when actual time extends much further out over the 90 to 120 days. The Government Affairs Committee of MMGMA started to review and discuss this problem and inequities in the provider credentialing process with payers in 2016 and have collected real-time examples of the above items. Again, this affects our patient care in that it delays the delay in the credentialing process harms our patients because it creates an unnecessary shortage in healthcare providers. Patients may be forced to choose to delay care or seek another provider. It needlessly takes away choice and could impact care. In late December of 2019 through March of 2020, the Government Affairs Committee met and worked with the Council of Health Plans, sharing ideas and real-time examples gathered from MMGMA clinic members. Our groups worked together to arrive at agreements in detail and language for a bill. Both the House and Senate authored bills during the 2020 session. Then came COVID-19, and that was the end of moving forward with the 2020 session. In late 2020, the Government Affairs Committee reconvened with the Council of Health Plans and again reviewed and agreed upon language to move forward in the 2021 session. Representative Morrison and Senate Abeler have authored House File 669 and Senate File 753. This bill is effective in addressing the need to streamline healthcare providers credentialing across payers, which all agreed is needed. It creates a definition for provider credentialing, which has never otherwise been defined by the legislature. It creates a standard and fair timeline for health plans to complete provider credentialing, which is 45 days from the date a clean application is received. It outlines what a clean application for provider credentialing is and what is done if a health plan determines that an application for provider credentialing is not deemed clean. It provides a timeline for that provider then to submit additional information. It provides a transparent, effective date, allowing patients to be scheduled proactively in a reasonable and fair timeline. House File 669, Senate File 753 is a bill that would improve patient access to healthcare by streamlining the provider credentialing process. This will remove barriers created for the patient as they would be able to schedule the provider of their choice. Thank you for your time.
Thank you. Senator Abeler, there is one other individual who would like to testify.
Let's do that,
Mr.
Madam Chair.
Andreessen.
Let's do that.
Mr. Andreessen. And Mr. Andreessen, I know Senator Abeler has an amendment. Were you to the bill or would you like to wait till the amendment?
Madam Chair, I can speak now. I just was following up on Ms. Reinhardt's testimony, just getting on the record that we appreciate MMGMA and other proponents reaching out. We definitely want to work with them and find solutions to problems that arise. And we appreciate them working with us. And as she said, we are neutral on the bill. And with that, stand for questions.
Okay, thank you. And Senator Abeler, to your bill.
Thank you, Madam Chair. And, this is the tip of the iceberg on some of the credentialing challenges. And I appreciate the hearing and this bill is worked out. But I just want to help people understand that when you finally get a chance to be offered the contract, it looks like this. And you can't change a word of it or you're clearly not wanting to be a part of their contract. And it's a take it or leave it thing. And there's, in a time when, particularly when a lot of the medical assistance is run through PMAP, the providers there, the carriers credential people. And so this delay has a very adverse effect, even on the lowest income families. who are the ones who very much need the care. And so here you have a provider willing to work in a medical assistance arena, be it a clinic or a hospital, and the people can't even get the care they need. So it's a very real impact on the real world. And so I'm glad that there can be a dent made in that. And Madam Chair, if I can, I'd like to offer the A1 amendment now.
Senator Abeler offers the A1 amendment. Members, I believe this was distributed to you in preparation for the committee, and it has been made available to the public. So Senator Abeler, to your amendment.
Well, thank you, Madam Chair. And amongst the features of these contracts, and particularly one very large carrier, they can terminate after you get a chance to get through the whole process of getting credentialed finally. They can terminate it without cause. Just it's part of this agreement that you signed. They can do it without cause. And if you take that out, they're not going to take you. And also, if they do terminate you for cause, there is no assurance they'll even tell you, give you a chance to even state your case and try to appeal what they may have misunderstood. There's no process. This amendment would simply say that they can't terminate you without cause and that there should be a process if they do. And Madam Chair, just to point out, if the bill that we're working on is controversial to have clean claims in 45 days, this is really reasonable, but it's controversial. And it's a funny we've gotten to this place in the world of healthcare that treating people as you would treat your neighbor would be considered controversial. And so, Madam Chair, I raised this only to make the point about the troubles. There is a bill that I'm going to introduce on this. And I imagine it faces a torturous route ahead. I would not want to put this good work at risk. And so I'm not intending to proceed with this amendment any further, more than to mention it. But Madam Chair, before I withdraw it, it seems Mr. Andreessen comes up there and there's so many reasonable things that can be done in healthcare with the providers and the plans to make it just sensible and normal and reduce the burdens on the providers that I'll continue my discussions with them, Madam Chair. And with that, I'll withdraw the A1 amendment.
Senator Abeler withdraws the A1 amendment. Thank you, Senator Abeler. Looking for questions from members. And not seeing Mr. Andreessen, you had testified. I'm seeing no further questions from people who'd given us notice they wanted to testify. So Senator Abeler, if you'd like to proceed to a vote, Senator Abeler moves that Senate File 753 be recommended to pass and sent to the Committee on Commerce. Members, for the vote, we're going to need you to turn on your video, unmute. All those in favor signify by saying aye.
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 Any opposed? Seeing none opposed, Senator Abeler, your bill is passed and sent to the Committee on Commerce. Thank you for your work
Thank you,
today.
Madam Chair and members. It's a small step for mankind. Thank you.
Thank you. And now, Senator Dahms, you have Senate File 694.
Thank you, Madam Chair and members. And Chair Benson, could you have somebody move the bill?
Senator Rosen is a co-author. So Senator Rosen moves Senate File 694. Please proceed, Senator Dahms.
Thank you, Madam Chair and members. Senate File 694 is the what we refer to as a reinsurance bill. And this bill is a pretty simple bill. What it does is extends reinsurance for the calendar year of 2022. And currently, this bill was put into effect in 2017. In 2016, the Affordable Care Act had kind of a reinsurance component to it. And that component ended at the end of 2016. If we all remember what happened in 2017, when the rates come out in the fall of 2016, we had rate increases in the individual market up to as high as 49%. We also had several insurance providers that left the marketplace and left our individual market in a total turmoil and pretty much collapsed the market. So at that point, we introduced the reinsurance program. And what that did is allowed the insurance companies to go into reinsurance at a $50,000 point where they would enter and come back off at a $250,000 point. and the insurance companies paid 20% and the state paid the 80%. That worked out very well, and it worked out to the point to where today in the 2021 market, we have another provider that's signed up. We now have six insurance companies participating in the individual market. We also have 22 plans within the market and within that group of providers. And county-wise, all counties have at least 2 insurance carriers and a minimum of 22 optional plans for them. Some counties have up to 5 carriers. And Minnesota right now is one of the lowest premium cost states in the nation. And a lot of that is due to the fact that we've used reinsurance. 14 other states have followed and put in reinsurance programs. Currently, when we put the program into effect back in 2017, we were required to put $542 million in this premium security account. The Department of Commerce or actuarialists come up with some costs, and we felt it'd be lower than that, but we did put the money in, and it came in considerably cheaper than what was expected. So today we still have money in that account. We have about $220 million in that account. $100 million of that will go to take care of year 2021. So that's going to leave, I think it's 118 point some million dollars left in the account after 2021, which we can apply to 2022. There'll also be, I think last year we got 89 million from the federal through the waiver process. And so there'll also be that, or maybe a little more for that. So we're looking at a total cost of about 200 million, and that will be picked up by those 2 premium security account and then whatever the waiver turns out to be. And also back in 2017, we had also applied for another waiver, and that was so that we would not be docked because we reduced the premium rates in the insurance industry. And we did not get that one, but it has been applied for again by the Department of Commerce and the Department of Health and Human Services. And so we'll see if we have better luck this time than we did last time. We'll have to see how that works. But so the money is in a premium security account, and it would take it for 1 more year. And so that's kind of what the bill does and kind of the heart of the bill. So I'll leave it at that, Madam Chair.
Thank you. Mr. Albrecht, we do have a fiscal note. If you could begin the walkthrough of the fiscal note for the benefit of the committee.
Madam Chair, given that this is the first complicated fiscal note we've had remotely like this, I wonder if it's easier if I direct you all to one part of the fiscal note that summarizes all of it, or would you rather me scroll through the whole thing and point you to different pages?
I would rather you give us a summary and then an explanation of the general fund. So just the front page summary, and then I do have some questions about the general fund in the first biennium.
So, Madam Chair and members, the best place to look at the summary is actually on page 3 of the fiscal note. And it's in the middle with the big number 1, where it says expenditures, absorbed cost, and transfers out. And then there are amounts there for the Commerce Department, the Human Services Department, and MNsure, and then the amount for each fund in there. And so what I thought would be helpful is to just explain what each of those amounts of money represent. As Senator Dahms indicated when he was presenting the bill, the Commerce Department portion is both the state and the federal share of the reinsurance payments, which total about $209 million. According to the Commerce Department's fiscal note. In the Department of Human Services, the Healthcare Access Fund portion there, the $55.3 million and $58.4 million, that is the amount attributable to the reduction in federal payments for the basic health plan for Minnesota Care. You'll remember that in that program, the state receives 95% of the amount of subsidy a person would receive had they bought a silver level plan through the health insurance exchange or MNsure. Obviously, if premiums are lower than they were going to be, then 95% of that amount of money is going to be lower than it would be. And that is what these amounts for the Healthcare Access Fund reflect. The amount in the general fund is not directly related to the insurance plan. Is directly related to the fact that in the November forecast in fiscal year 2024, the balance in the Healthcare Access Fund was 0. And in current law, there is a contingent transfer that goes from the Healthcare Access Fund to the general fund as long as there is money in the Healthcare Access Fund to pay for it. So in 2024, because that number is 0, the balance is 0, this amount of reduced revenue has the related effect of reducing the transfer to the general fund that depends on some balance being in the Healthcare Access Fund. So that 113,673 is the total of the other two numbers of the 55.323 and the 58.350. Any questions about that?
I'm sure there are, so I will pause. Members, questions to the fiscal note. Senator Wickland.
Thank you, Madam Chair. I was just wondering, Mr. Albrecht, if you could just repeat again what you were saying about the Commerce Department. I just repeat that, I guess, what you said about that. They're the line items that relate to the Commerce Department.
The $123.8 million is the state's share of the reinsurance payments, and the $86.1 million are the federal share of the payments. I would point out that if you go down to the Commerce Department's section, they make assumptions that that lead to a result that this is on page 6 of the fiscal note. They make assumptions that lead to the result at the end of fiscal year 23 of a negative balance in the reinsurance fund. And that's not really, I don't think, how it would end up working. Obviously, you can't do that. And the EMSA board that administers this program has the authority in law to adjust the parameters of the reinsurance program to match whatever money is available. I think Commerce did what the only thing they could do, which is assume that the parameters are going to be the same because they don't have any basis for deciding how the board would change them. But I don't think the result of a negative balance would be the result at the end of the day. But that doesn't mean that well, I guess it does mean the payments, the total payments would not be $209 million. They would be $5.4 million less than that if everything stayed the same, which is not probably very likely. And if you read the Commerce part of the fiscal note, they do discuss all of the places there is uncertainty in their estimates. And then, Madam Chair, I'd just like to talk briefly about the MNsure part, going back to page 3.
Mr. Albrecht?
Yes.
Go ahead.
So with MNsure, the revenue for MNsure is also tied to the premium amount. They are funded by a 3.5%, I think, withhold from the premium. So when the premium is less the amount of revenue from MNsure is also less. MNsure does make an assumption in their fiscal note that their reserves are insufficient to operate at their current levels with reduced revenue. So they make an assumption that there would be a general fund appropriation to, I guess, hold them harmless from the reduction in their revenue caused by continuing the reinsurance plan. And that is, you know, the $2.6 and $2.5 million in that part of the fiscal note.
Okay. Thank you, Mr. Albrecht. Any further questions to the fiscal note? I did see some concerns with the MNsure portion. They contend that even with a 20% increase in premiums, that per member per month participation will remain constant. I find that to be implausible. And so there's some work to do on this fiscal note. Our next stop will be finance, but to be clear, members, the general fund expenditure from MNsure on here isn't currently required by this bill. It is a secondary, perhaps even a tertiary effect. And so there's some significant work to be done on their assumptions here.
Madam Chair and members too, you might recall from 2019?
17?
No, the last time we extended the reinsurance, 2019.
19, yes.
This issue with MNsure also existed, and it was not addressed until the Omnibus Human Services Bill was completed in conference committee. And there was a general fund appropriation made to MNsure at that time, but it was not in the reinsurance bill itself.
Thank you. Seeing no further questions, Senator Dahms.
Thank you, Madam Chair. I just wanted to weigh in on page 6 of the fiscal note. It shows a $5,395,000 deficit at the end of the year 2022 of the plan. Keep in mind that that does not include any interest that would accrue that year, does not include the normal increase we get per year from CMS. So that number may easily be less than that or erased.
Thank you.
Thank you, Madam Chair.
Senator Dahms, there are a number of testifiers. So we'll move to, I have a list, Mr. Bentley Graves, Mr. Dan Dwight, Mr. Dan Andreessen, and Mr. Al Cruz or Cruzy. So that will be our order. So Mr. Graves, you are first on deck, or you are first, and then Mr. Dwight, you are on deck. Please turn on your video, your microphone, and proceed.
Thank you, Madam Chair. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. The Chamber represents about 6,000 employers across the state of all sizes, all industries, and all corners of the state. We work on healthcare issues because it's an incredibly important benefit, both for keeping employees healthy and productive at work, and also as a tool for attracting and retaining talent. But it's also a benefit that's very expensive for employers. Now, when it comes to reinsurance, some have wondered what interest kind of the broader business community has in what's happening in the individual market. But of course, the individual market is an important place where self-employed individuals go, entrepreneurs go for coverage, but it's also an increasingly important outlet for some small employers and their employees to find coverage. And this is especially true now, given some of the allowances that the federal government has recently made for employers to use HRAs to help their employees buy their own coverage. Just to kind of underscore this point, we survey our members every year on a whole host of issues, including healthcare issues. And this year, we asked a couple questions related to this, and 25% of our members who currently offer insurance reported that they would begin considering these defined contribution options if healthcare costs continue to rise at their current rate. And similarly, 20% of those who don't currently offer insurance or coverage have reported that that they're going to be looking at these options to provide some level of coverage and help their employees buy coverage of their own. So these kind of emerging trends just underscore the importance, in our view, of maintaining health and stability in the individual market. And reinsurance has done just that. As you've heard from Senator Dahms, rates are in the individual market today 20% less than what they otherwise would be without reinsurance. And we also know from testimony in the House hearings on this bill that rates will go up as at least 25%, if not more, if reinsurance isn't extended. And so from our perspective, it's very important that the reinsurance program be extended. And I think it's also important to note, as Senator Dahms said, that this is something that can be done without the addition of any more state resources. So I want to reiterate our thanks to Senator Dahms for bringing this bill forward and for the role that he's played over the last several years in ensuring reinsurance is there as a stability mechanism in the individual market. I want to encourage members of the committee to support this bill and support continuation of reinsurance and the important role that it's played in bringing stability to the individual market. And I'm happy to stand for any questions you may have, but thank you, Madam Chair and members.
Thank you, Mr. Graves. Next, we have Mr. Dwight and then Mr. Andreessen. Please proceed.
Hi, thank you, Madam Chair, members of the committee. For the record, my name is Dan Dwight. I am here today on behalf of the Minnesota Business Partnership. We are a membership organization consisting of business leaders from across the state that employ more than 500,000 Minnesotans. We are very happy to support the extension of the Premium Security Plan, commonly known as reinsurance. As we've heard in testimony and discussion earlier today, the individual marketplace in Minnesota was in peril. We had double-digit premium increases, and we were seeing the loss of health insurance options in many parts of the state. And I think it's been proven that reinsurance has really helped to stabilize the market. This has been a nation-leading program. We've had probably at least a dozen other states that have modeled their programs after ours because it's been proven successful. And of note, this program has really helped to reduce cost shifting, and that's an important effort that we need to undertake. It has also really helped to maintain healthcare access in all parts of the state. And, as we've heard earlier, this program has helped to reduce health insurance premiums in the individual market by 20% or so. And if this program were to expire and go away, we're looking at an additional 25% premium increase in the individual market. Additionally, this program is fully funded, and we just simply need to extend it. And doing so will help maintain the stability in the individual health insurance market during this time and help maintain solvency for our healthcare providers across the state. I echo a lot of what's been said, especially from Mr. Graves. I stand ready for questions, and I thank you for your time today.
Thank you. Mr. Andreessen, followed by Mr. Cruz. Mr. Andreessen, please proceed.
Thank you, Madam Chair, members of the committee. My name is Dan Andreessen with the Minnesota Council of Health Plans, the trade association that represents Minnesota's 7 nonprofit plans. Thank you for the opportunity to testify today in support of Senate File 694. Minnesota's reinsurance program was created to lower premiums for people buying insurance on their own by paying a portion of the high-cost medical bills, which is a cost that otherwise must be built into premiums. And the program has been a resounding success. The program helps protect access to a variety of individual health insurance options in every corner of the state by minimizing the risk of high healthcare costs. As a result, more insurers have been able to stay in the market. States without a reinsurance program continue to see insurers leave their markets, and insurance options are decreasing. An advantage of the program is that it doesn't affect a consumer's healthcare experience. The operation is seamless to consumers, and those with high healthcare costs don't have to complete extra paperwork or enroll in a special program. The reinsurance program is administered by the Minnesota Comprehensive Health Association, who ensures the program's money is used appropriately. Financial information is summarized in quarterly reports posted publicly on the association's website. As Mr. Dwight mentioned, the program's been so successful, 13 other states have enacted similar reinsurance programs over the past several years, and Congresswoman Angie Craig is the author of a bill to create a federal reinsurance program. We urge the legislature to pass this legislation quickly. The Minnesota law requires health plans to file products and rates in the next coming months for calendar year 2022. and passage of Senate File 694 will ensure that the benefits from the reinsurance program are built into 2022 insurance rates. Passage of this bill will help keep the individual market stable and affordable. And as comments have been made already, we could see an increase of maybe 25% in 2022 if this program ends. And this kind of increase will impact the ability for Minnesotans to remain covered. And the COVID pandemic has illustrated the need for health insurance, and now is not the time to destabilize the market and increase premiums. The council thanks Senator Dahms for his leadership on this issue and asks for your support to maximize the state's 5-year reinsurance waiver and keep the program going through 2022. Thank you.
Thank you. Mr. Cruz. And I haven't.
Can you?
Welcome to the committee. If you can turn on video, we'd appreciate it, but we understand that's not always possible.
I'm trying to turn on the video and it's not cooperating with me, but anyway. Oh, there it is. Madam Chair and fellow senators, I appreciate the opportunity to testify. My name is Al Cruz. I'm retired and live with my wife by Marshall, Minnesota. And this opportunity took me down memory lane a bit. In the 70s, I worked with clients who had chronic illnesses and couldn't get insurance. And so we steered them to the high risk pool, which was the reinsurance program of the time. And it worked very well for those we could get to transition into employer sponsored insurance, group insurance. For those that didn't have that opportunity, it didn't work that well because it became unsustainable on the premiums and the co-pays. It also took me down the lane to 2016 to the healthcare, what was the name of it? It was the task force, the healthcare task force appointed by the governor at the request of the legislature. They met about over 80 times. I testified a few times before different committees. And in 2016, they presented 20 suggestions to improve healthcare to the legislature. And I'm sad to say that exactly 0 were discussed or adopted. And it is my hope that, in addition to extending the reinsurance to bridge things over, that maybe someone on the committee would dig out those 20 recommendations and bring them forward. Because if our goal is to improve accessibility and affordability of healthcare, we need to improve what we're doing. And that's just my respectful suggestion to the group. And I thank you for the time to testify.
Thank you. Questions from members? Seeing no questions, I'm being very patient because I've got a lot of people on my screen here. There's Senator Wickland. Thank you.
Thank you. Yeah, I have another, I guess, a fiscal question that maybe Mr. Albrecht can answer. With the amounts that are in the fiscal note as in the Human Services Department section that are showing as coming from the Healthcare Access Fund, are those amounts, do those represent the entire reduction in federal contributions to the basic health plan, or is that something less than that, just the amount that has to be offset by the Healthcare Access Fund?
Mr. Albrecht?
Madam Chair and Senator Wickland, it's the change in federal revenue for the basic health plan, all of which happens within the Healthcare Access Fund.
Okay, so that will show up all together in those amounts that are listed.
Yeah, there's no part that's somewhere else, if that's what you're asking.
Yeah. Okay. And then I guess with this fiscal note, and not a question for Mr. Albrecht, but it just, with this fiscal note, it seems like there are things that are not included because they don't have the information yet. And I guess one question would be to Senator Dahms. Is there a reason that we can't get that information and I mean, we can't wait for that information to be available and then have a truly complete fiscal note? We're trying to decide on this bill, and it's allocating money, and it's taxpayer money that's going towards this. Wouldn't it be better to have a completed fiscal note before, fully complete fiscal note before we move forward and pass this bill?
Senator Dahms?
Thank you, Madam Chair, and Senator Wickland, thank you for the question. The reason that we're moving the bill forward is CMS under the Biden administration, they have not appointed a person yet. So we have no idea how long this might take for them to appoint somebody and to get this information back. And so we have chosen to move forward with it, and hopefully they have some information down the road that we can plug in. But if not, we will have to move forward on the basis of what we have. Thank you for the question.
Senator Wickman?
Okay, thank you, thank you, Senator Dahms. I guess my question then, I was wondering if there is somebody on from Commerce that I could ask a question of.
And Mr. Brickwitty is available. I will let him unmute. Welcome to the committee, Mr. Brickwitty, and Senator Wickland, proceed with your question.
Yeah, I was wondering if you could comment, Mr. Brickwitty, about whether there's pieces of information that are not, that you had to make estimates on, that we are going to be receiving within a known time frame that would affect this fiscal note and might affect the way we look at the bill based on changes that will happen with the fiscal note.
Mr. Brickwitty?
Madam Chair, for the record, Peter Brickwitty, Assistant Commissioner at the Commerce Department. I think Mr. Albrecht for his stepping through of our portion of the fiscal note earlier, and I would concur with his analysis. I think I would characterize our fiscal note as evolving based on information that we are still waiting to receive. So as Senator Dahms indicated, we do not, for example, make an assumption about earned interest income for FY23. That is consistent with our assumptions in the fiscal note on the proposal 2 years ago as well. We are overdue for the federal government to provide us with an estimate of the federal pass-through amounts for the current plan year 21. So that is why we have, again, consistent with our assumptions from 2 years ago, assumed that flat $86 million approximately federal funding amount. I would concur with Senator Dahms that we hope amount will increase, but we don't know yet that for sure. We hope to have that number any day, but we were due to receive it, I think, by Halloween, and so we have not received it yet. I think we're also very close, obviously, as members know, to the February forecast. And so if there are adjustments made there, I think that will likely influence our fiscal note assumptions here as well. For example, MSHA's actuarial committee just released, I think since the committee hearing on Monday, the updated actuarial analysis of the Q4 data that came in, which I think shows some additional, like $2.2 million of additional expenses there that were not assumed in the November forecast upon which our assumptions are based in our fiscal note. So I think that would take that $5.395 million balance or deficit on page 6 of our fiscal note and bump it up by $2.2 million once we have that incorporated into the forecast. I think, as Senator Dahms indicated, that change in federal amount will certainly also offset this as well. So I think, Senator, that is a long-winded answer of saying this is a lot of moving pieces in real time, just a function, I think, of when we're having these committee hearings this week. And so those numbers may change even perhaps if we were to say get the federal funding amount this afternoon, I think we would do everything we could to have an updated fiscal note for Senator Rosen's committee tomorrow.
Senator Wickland, anything further?
Not right now. Thank you.
Thank you. Members, further questions? And Senator Rosen, well, this is scheduled for Senator Rosen's committee, I believe, tomorrow morning. Let's see, Senator Klein and then Senator Rosen. Senator Klein.
Thank you, Madam Chair. Thank you to the presenters and the testifiers. So yeah, I guess just a little bit of follow-up on that question of timing, because it seems fairly important. And in particular, we have sort of a time certain for the forecast, and that'll be a big piece of the puzzle that I would like to see before voting on such substantive and expensive legislation. But Mr. Brickwitty, the question about sort of that pass-through money and how it may come any day now, I guess is how you characterized it. Does your office must have some sort of estimate of when you anticipate that might arrive, or you may have been in communication with your federal partners? I mean, how far out in a bad scenario would it be that we would have those numbers so that we could make a reasoned decision going forward?
Mr. Brickwitty.
Madam Chair, Senator Klein, I don't have a good answer for you. We are due to receive each year of the reinsurance program's operations. We are supposed to, under our waiver agreement, receive that estimated federal amount of pass-through by the end of October each year. We're obviously past that and have not yet received it. We have made our staff level contacts aware at CMS and Treasury that we'd like to have that number so we could update for the forecast. We also made them aware that we had at least 2 hearings scheduled, and this week, and if we could get that information from them, we would incorporate it into our fiscal note analysis for you all as quickly as we could. So we have put in that request. I can't definitively answer for the federal agencies on when they'll provide us with that number, however.
Thank you, Senator Klein.
No further questions. I guess I would still prefer, candidly, Madam Chair, that we table this motion until we have a little more data. I'm not going to make that motion and interrupt, whatever your agenda is for this bill moving forward. But it would seem to make sense to me that we would at least give it another week and have a more informed vote.
Thank you, Senator Klein. Mr. Brickwitty, there are 2 pots of federal money that we deal with reinsurance. One is directly related to the premium security account, the other to the BHP. And as Senator Dahms referenced, there was a letter regarding the perhaps change in policy with the new administration. Do you have any sense of when there might be resolution on the BHP letter?
Madam Chair, thank you for that question. So on February 5th, 2 weeks ago now, Commissioners Arnold and Harpstead sent a letter to the acting CMS administrator requesting that the Biden administration review the decision by the Trump administration not to approve the state's 1332 waiver in full when we initially applied for it. I'll defer to my colleagues from the Department of Human Services to delve more into the impact of the existence of the reinsurance program on the BHP funding formula if committee members are interested in that. But I think to your question, Madam Chair, about I think we are cautiously optimistic that we may get a different answer from the Biden administration than we did from the previous administration, but we do not have a timetable on when we may get a decision from them on that. I think there would be many technical issues that the state and federal staff would need to work out the mechanics of, but that may be something that we're able to provide updates to the committee on as we move through session.
And Mr. Brickwitty, and I can raise this with Commissioner Harpstead under a separate circumstance, but when we were dealing with CMS in 2017, CMS gave us assurances, but it was Treasury that made the decision on BHP funding. And I don't remember the letter being addressed to Treasury, just to CMS. Mr. Brickwitty, can you help me correct my understanding?
Madam Chair, I think we sent the letter to the acting administrator at CMS. I think there is a reference to CMS and Treasury jointly entering into that information. I think the reason why the letter was sent to CMS is because the denial letter came from CMS back in 2017.
Okay. Thank you, Mr. Brickwitty. Further questions? Thought I saw Senator Rosen's hand for a moment, but I'm not seeing it now. Senator Dahms, to your bill. Oh, Senator Wickland has her hands raised. Senator Dahms.
Thank you, Madam Chair. I guess I'm not sure. Are you ready to move to take a vote on the bill at this point? Are you?
It is my intention to move this to finance.
Okay, and if we're to the point of making comments, I do have some comments to make about the bill. Okay.
Thank you. Proceed, Senator Wickland.
Okay, thanks, Madam Chair. I'll do that now. And I appreciate the information that was presented, and I appreciate that that the plans and others have an interest in seeing premiums be stable again for one more year. And I do have a lot of concerns about a couple of major things. One is that we have just this one more year of the waiver request that will extend it for the until the end of 2022, and then we aren't going to be able to keep extending this program. That's the last year. So I guess one of the big concerns I have is that we haven't had any indication about, what is the plan after this, what's the plan for after this reinsurance program. And it seems to me that we should be having a discussion about that this year, since it would, any different option would take effort to put in place and discuss with all the stakeholders. So I really have concerns about just moving forward with this bill and extending for one more year with really nothing included to say what we're planning to do going forward. I also just have concerns about reinsurance. It seems to have the implication that it has worked, although I think I still hear a great deal from constituents that the individual market plans, may be affordable or may not be affordable even, but deductibles, co-pays, co-insurance are all really expensive and really not affordable for a lot of people. And on top of that, prescription drug prices are very high and not affordable for people. So I feel like this solution is not getting at the true problems that we have with healthcare. The premiums, deductibles, and so on are not affordable for a lot of people. And to the extreme, I mean, you find in testimony that we received written testimony about the extreme unaffordability of premiums and costs, healthcare costs for many rural Minnesotans. So I do have great concerns about just moving forward with this so quickly. We don't have all the financial information, and we're voting on it anyway. We're also not considering how we might want better address health care outcomes. The current reinsurance plan doesn't have any leverage for the plans to be trying to improve outcomes in health. And I wish that we were putting something forward that did not only stabilize premiums, but also incented the plans to be working towards better health care outcomes so that we are improving Minnesotans' lives as we do implement these programs that do cost taxpayers money, significant sums of money. So those are my comments on the bill today. Thanks.
Thank you, Senator Wickland. Senator Draheim.
Thank you, Chair Benson, and thank you, Senator Dahms, for bringing this bill forward. For me, in my district, this is a huge bill for the smaller farmers and people with pre-existing conditions, et cetera. So thank you for bringing it forward. And to Senator Wickland, I have a few bills that address those issues that you brought up. So I'd love to sit down and talk to you with you and talk about drug prices or other ideas that we could do to help lower the cost of care. But once again, thank you, Senator Dahms, for bringing this forward, and Senator Benson for hearing it.
Thank you, members. I wanted to reorient folks a little bit. We did have a market stabilization tool in place prior to the Affordable Care Act. We had many more choices and much more flexibility in the individual market. And while it was difficult to call those plans affordable, they definitely had a higher uptake than our individual market does at this point. But the Affordable Care Act took away our option to have a premium assessment, sort of a covered lives assessment. And so we then had to look for a new way to stabilize the market when the reinsurance program that was in the federal law expired. And so we actually copied that reinsurance program, gave incentive for costs to be controlled on the high end of care. Most people don't access high cost care, but reinsurance does expect that the health plans will manage the higher cost cases because they have more of a burden to bear once they've gone through that middle range of reinsurance. And so, no, this is not ideal, but we did have a plan and it worked for a lot of Minnesotans, more Minnesotans that are in the individual market now. I hope, as Mr. Graves discussed, using a premium aggregator and a defined contribution plan will relieve some of the burden on employers, get more people into the individual market, which helps stabilize it without any artificial mechanism. And because employers could do that pre-tax, it levels the playing field a little bit between employers who can do all of their healthcare without tax consequence to the employee and small employers who would have to give somebody a raise in order to help them with their health care. And so, no, this isn't ideal, but there are mechanisms in place to help improve the individual market in Minnesota. I would also say there's going to be some changes in healthcare at the federal level. And again, we're going to go through a period of uncertainty. I'd like this tool in place to create some stability while we watch to see what's going to happen in Washington. Senator Abeler.
Thank you, Madam Chair. And I'm driving, so I can't go to video, but I've just come from the Red Green show here. I just wanted to comment about the, like you mentioned, the MCHA program, which at the time people thought, oh, this is sure a lot of money. Just one of the negative consequences of the Affordable Care Act, which a lot of us had concerns about. An MCHA program right now, Madam Chair and members, would be a dream plan for people. It was a modest deductible 80-20, and compared to what premiums are now, it would be a remarkable thing to come across something as good as that. It's probably half the price or less than what we've gotten to now with the changes that have been wrought by the national system deciding they wanted to improve on our healthcare. So I think this is a really good idea to do the reinsurance. It's certainly a workaround that, I don't know, I'm not even sure we should ever meet it, but here we go, Madam Chair. But I certainly favor this proposal today, and it's a really good discussion. And
thank you.
Thank you.
Thank you, Senator Abeler. Senator Dahms, closing comments, and then I'll have Senator Rosen move the bill.
Thanking our committee, Madam Chair, for hearing the bill and thanking the members for their questions. Just remind people it's not a silver bullet, but it's probably close as we're going to get. When we take a look at the way the market got blown up in 2017 with the Affordable Care Act, if you wonder where we'll be at in 2022 without this, just rethink 2017. Thank you, Madam Chair.
Thank you. And members, I'm going to ask you to turn on your video and your microphone. Senator Rosen recommends that Senate File 694 be recommended to pass and sent to the Committee on Finance. All those in favor say aye. Aye.
Aye.
Opposed?
No.
No.
Thank you. With that, members, Senate File 694 has passed to the Committee on Finance. Thank you for your attention today. Next, I'm checking with Ms. Strand. We had invited guests from West Virginia to join us. They will be here shortly. And she will signal me when they're here. So the Wall Street Journal highlighted that West Virginia had the most successful vaccine rollout in the country. And recently Bloomberg ranked them as #1, and Minnesota was 26th in the Bloomberg report. Bloomberg similarly had done a testing report that put Minnesota, I believe we were #1, if not we were very high in our testing capacity and outcomes. But on vaccines, the Bloomberg report indicated that we were short. And one of our responsibilities is to learn from other states. We are laboratories of democracy, and we are laboratories of economics. And I wanted to reach out and see how West Virginia varied their decision-making. And I see Dr. Marsh has joined us now. Welcome to the committee. Dr. Marsh, could you please briefly introduce yourself and what your role is as part of the COVID rollout?
I would be most delighted to, and thank you, Senator Benson. And it's really a privilege to share any findings that might be able to help. So my name is Clay Marsh. I'm a physician, and I oversee the health side of West Virginia University. And at the beginning of the COVID pandemic, was asked by Governor Jim Justice to oversee the COVID response in the state of West Virginia. So I got the title of the czar, which I'm not sure is a good title since most czars die very untimely deaths, but nonetheless. So, but it's a privilege to be here with you today.
Thank you, Dr. Marsh. And I believe Indiana also almost immediately appointed somebody who, not a science czar, but a special consultant to the governor to deal with some of their concerns. So Dr. Marsh and members of the committee, please raise your hand if you have questions as we go forward. Your vaccine rollout was very successful. So a couple of questions to start. When did you start preparing for the vaccine rollout? And what do you think were some key decisions that set you apart in success for the vaccine rollout?
Well, thank you, Senator Benson. I think that, one of the key findings that is really important, that every state has their own unique issues that they need to solve for efficient vaccine rollout. We created a team that was really 3 of us with directly reporting to the governor. It was me, who was appointed to the central coordinating role, the head of the National Guard, that were really logistics and disaster management response folks, and then the secretary for the Department of Health and Human Resources. And that was the policy part and all the other issues that were germane to this problem. And we created a team structure. So when the vaccine became available and we knew it was coming, it was easy for us then to pivot to make some plans. And I think that the critical pieces, and I'll be short with my answers and be guided, but the critical pieces was, number one, we were very clear at the state level of what the mission was. We were going to save lives and improve well-being and maintain capacity in hospitals and communities. And number two, we were really clear on our prioritization for our vaccine group. We followed the Advisory Committee for Immunization Practices from CDC. So our 1A was healthcare workers, particularly ones in the COVID front lines, and nursing homes and nursing home residents and folks that work there. But because we looked at our own epidemiology, we figured out that, half of our deaths were in nursing home patients. The average age of death in West Virginia was 77 years old. Greater than 70% 94% of our deaths were in over 70-year-olds, 92% of our deaths were in over 60 years old, and 97% of our deaths were in people over 60. And because of that, I'm sorry, over 50. And because of that, we were really clear then that we wanted to really quickly target this population. And in order to build the ability to be more dynamic and flexible and agile, we created a kind of a team of teams, which we call the Joint Interagency Task Force. And as part of that, we have 15 different sectors represented around the table, including healthcare, long-term care, FEMA, local health departments, hospitals, et cetera, along that's overseen by our National Guard, who are our logistics experts. And as part of that, and I'll finish after this statement, as part of that, we initially knew that we wanted to get to our nursing home population very rapidly. And we were worried about chain of command for the vaccine because at that time we hadn't received any yet and Pfizer needed ultra cold storage. And so we were worried about the distribution of that. So we decided, one, pharmacists were going to take care of the vaccine. They still do. They manage the vials, they drop the doses and then give it to the vaccinators. And number two is we looked to see how we were going to move vaccine. And we figured out that the federal pharmacy program that was really targeted to Walgreens and CVS really didn't have the level of distributive footprint across all parts of our rural state. And we figured out that we had about 250 pharmacies, about half of which were privately owned. So we then determined that it was better not to activate the federal pharmacy program. But then we met with Operation Warp Speed and told them what we found after we did our homework. And they said, absolutely, sounds good for West Virginia. Don't turn down the program, just don't activate it. And today we've activated now the federal pharmacy program so that we get extra doses for the state. But by deciding to move with private and small community pharmacies, we were able to get many more people, about twice the national average of nursing home staff sign up to get vaccinated, and about 85% of our nursing home residents. And we're able to deliver those doses, first doses in arms before the end of 2020, and second doses in arms about 2 weeks ago. So we've completely vaccinated all of our nursing home residents. And over the first 5 weeks of 2021, we've seen a 70% reduction in deaths in West Virginia and about a 60% reduction in hospitalizations.
That's really impressive. I do have a logistics question. First of all, are you a fan then of General McChrystal if you implemented
Team of Teams? So his co-author was just on the last Zoom I was on, who lives in West Virginia, by the way. So we're
wonderful.
At him quickly. Love that book. Yes.
It is a great management type book. Anyway, we're off topic, but I wanted to ask, when you decided to not go into the federal pharmacy program, did you lose those doses then, or did they get shifted? Were they retained for you in some way that you didn't go with Walgreens and CVS? Did they just send them somewhere else, or were you shorted doses?
No, what we decided to do, and again, this is the reason why communication is really important. We talked to Operation Warp Speed leadership and we said, we found this out. Do you guys agree? And they said, yes. So we didn't get reduced any doses. We created 5 hubs around the state that were logistically placed, cold storage, backup generator, but placed so that we minimize drive distance between any part of West Virginia and one of the cold storage places. So we have 5 hubs receive doses in. Those doses are then, moved to the appropriate next places managed by pharmacists all the way through. And we track them with GPS and we keep track of every dose. So we know where every dose goes. And our commitment is every dose has to be in an arm by 7 days or it gets reclaimed.
And how do you manage, when you thaw the Pfizer dose or the Moderna dose, they're only good for so long. How do you manage the logistics of not having extra doses wasted?
So we, for instance, let's say the nursing homes as just an example, but I could give others too. So what we did is we decided that the Pfizer doses should go to more larger nursing homes that have more central location closer to the hubs. so that we didn't have to, to move the doses as quickly. And we're able to move the doses in cold storage, and we land them then, if they're not used immediately, into other cold storage facilities that are close to the place we're using it. So for instance, we have nursing homes in Charleston, which is close to one of our large health systems, Charleston Area Medical Center, and in Morgantown, which is close to West Virginia University. So those doses could sit in the hubs for the, could be stored then for use by these other partners, for instance, so we wouldn't waste any doses. But we allocate doses sufficient to be used in a short period of time, and then generate the cadence with the teams that are responsible for administering the doses, whether it's local health departments, hospitals, or nursing homes, where we basically are assured of the rate of usage. We also have 2 levels of a backup system in case people don't show up or in case there's extra doses. Every dose gets put in somebody's arm, and we are very committed to trying to get 6 doses out of each Pfizer vial to the level we can, and 11 doses out of every Moderna vial. But that's always done by the pharmacist, and we're clear that it needs to be a full dose, and there can be no batching, there's no pooling. And so by having those, criteria and expectations, it's worked really quite well.
Can I ask another logistics question? How did you get people to sign up? Did you have a tool? Was there something in existence that you already leaned on?
We went through the same challenge as everybody else has. So we had a lot of lists at local health departments, lists at private, group practices, hospitals. And we got a lot of feedback that was really confusing for people. Like, what lists, how do I get on, who do I contact? So we've created now a state pre-registration system, and we partnered with a company that manages disaster communications called Everbridge. And so now we have a single state registration system, and we're moving all of those sub-lists onto this one queue. And we are able then to sort by priority status, whether it's age, essential worker, et cetera. So we've created a master list that we are using. We have now put about 250,000 West Virginians out of probably still, 1 million plus people that need to get into the list. But we're trying to put every West Virginian who hasn't been vaccinated into the list at this point.
I appreciate that. Just the logistics. And you started planning when you first heard about vaccines. So would you target that as March, April? When did you start developing the core team?
Yeah, the core team was existing. So we've created this team from the very minute the pandemic started. So we've been together almost a year now in our function. And so we work really well together. The vaccine management component, though, started in December.
Okay, thank you. I'm looking for questions from members. Don't be shy, Senator Curran.
Thank you, Madam Chair, and I appreciate your participation, Mr. Marsh. So more specifically, we've known the over age 65 population has been the most impacted. Where are you in this phase of the deployment of the vaccines? What percentage of your overall vaccines are being deployed in the over 65 population as of today?
So we have deployed a
Dr. Marsh.
Thank you. We have deployed a total of about 365,000 vaccines so far. And I think that's around 12+% of our population. Actually, it's more than that. So we were 1.8 million, so it's about 1/6 of our population. So we have about 350,000 West Virginians that are over 65. We have given at least one shot in about 155,000 West Virginians so far, and 2 shots in about 60,000 West Virginians over 65 years old. As a per capita part of our population, by far the majority of shots on that basis has gone into over 80-year-olds, and then in over 70-year-olds, and now into over 65-year-olds. And if you look at our own data, it was really compelling. But the piece of data that really convinced us, and Dr. Deborah Burks was a big proponent of this when she came and helped us a couple times too and visited. But I don't know if you guys are aware of this data, and I don't want to waste anybody's time, but I do think this is mind-blowing data. So this is from CDC from August. So if you take a group of 18 to 29-year-olds with COVID as the healthiest part of the population, that's the comparator here, okay? And if you then take 65, if you take 50 to 65-year-olds, okay, as the first group that you look at, and you look at the risk of dying from COVID-19 if they're infected and the risk of hospitalization. And remember, I said our number one priority was save lives. And then one of our other priorities was reduce hospital, maintain capacity. Because when you overwhelm your hospitals, you start having deaths from heart disease and strokes and, all that. So when you look at 50 to 65-year-olds, risk of death versus 18 to 29-year-olds with COVID is 30 times higher. Risk of hospitalization, 4 times higher. When you go another decile, when you go 65 to 70.
Daddy, I'm having all kinds of technical issues. Now my...
Senator Nelson, if you could mute yourself. Thank you. I apologize. Please continue. Those statistics are not boring. Please continue.
65 to 75, risk of death is 90 times higher, and risk of hospitalization is 5 times higher. If you go 75 to 85, risk of death is 220 times higher. Risk of hospitalization is 8 times higher. And if you're over 85, your risk of death versus 18 to 29-year-olds is 630 times higher, and your risk of hospitalization is 13 times higher. So that data to me is so compelling that, that moving very rapidly to the older part of our populations is a critical strategy, in my opinion, that not only saves lives, and I told you we've seen almost a 70% reduction in our deaths from the first week in January to today, but also we've seen an almost equal reduction in hospitalizations. We have fewer people in the ICUs than we've had since November, and we have fewer people on ventilators than we've had since November, early December.
Wow. I had not had those statistics laid out for me that way. Thank you. Senator Coran, you're still unmuted.
No, excellent. Thank you, Dr. Mars. That was probably the most useful information we've had in the last 4 weeks as it relates to how somebody have easily explained the target and how you achieve the goal. And it's been very clear since day one, and it looks like you guys did a great job at accomplishing it. So thank you.
Thank you.
Thank you. Anything further, members? I know Dr. Marsh has other things he needs to do. I'm seeing no further hands.
Senator Benson, can I make one other comment? Just,
Please.
Again, we're all learning. I mean, this is all building the plane while we're flying it, and I think that's true for everybody. I think a really critical issue for any state is to one, really, it's like the Oracle of Delphi, know thyself, know thy state, know your data, but also look at this like a rapid learning system. Because if you get too set in what you're going to do, this thing changes so dramatically. And so I would say, don't be afraid to make mistakes and to empower people to move quickly. Moving quickly, that team of teams idea is really important. And then the other thing that I think is really important is we've been very intentional about creating our own supply chain. So for instance, we are worried about variant viruses like everybody else, but we decided that, with all the challenges in the country, that we were going to create that ourselves. So in 3 weeks, we now have whole genome sequencing to be able to look at virus variants. And we've just run 98 samples. And so we're moving. And of course, we're working with CDC and we're not being isolated. We're sharing everything we can. But the more self-sufficient you are and leveraging the assets that you have. So for me, being non-government, I'm a government employee because I'm a university person, but not being in politics or in government, I can bring a different sort of look at things, and we can muster the power of the universities to solve some of these problems. We've made our own PPE, we've designed our own N95 masks, we've made our own PCR tests, our own antibody tests. We've done decontamination and fit testing in our inhalational toxicology area. I mean, Minnesota's got tremendous, healthcare, universities, academics. You have so much talent there, but I think sometimes we just don't unleash the power of that talent in a way that really does serve the citizens and solves the real problems of the state. I would really encourage you guys to think about that. Anyway, that's my other thought.
Thank you. Senator Abeler.
Well, thank you. And Doctor, I just thought I'd welcome you to shoveling snow in Minnesota. You must have snow there sometimes too. Anyway, this is really fascinating. Could you just comment on kind of the style of how you organize, or how West Virginia organized? Would you say it was kind of like top down, kind of like some people helped, or you had a broad cooperation like with the legislature and so on? Just kind of, it seems like I'll let you answer the question. Thank you.
Dr. Marsh.
Thank you for the question. It's really interesting that I feel like that my whole role in this pandemic, so I'm like the science medicine part of the team, and I bring a lot of stuff that I'm learning, but this is really a team, and what we've done is we've been able to park egos at the door, and we've been able to work together really, really well, and we're all wearing one hat. I mean, we're trying, it's great that we've done well statistically, but we're really trying to save people's lives. Kaiser Family Foundation rated West Virginia as the most vulnerable state in the country going into COVID. We would probably have done the worst. And the key is, the reason why we've done pretty well is because we have stayed together. There was, and I'm pretty passionate about this, so I'll try to be really short, but there was an article in the Washington Post at the very beginning of this, and it expressed 4 different mathematical models for COVID. And this was at the time we were worried about a hospital surge, so it was like staying at home. But the 4 models are, and these are called agent-based models, which is a way that you can sort of model for complex behaviors. And the first model is you don't do anything. The second model is you quarantine everybody by force, by law. The third model was you get people to agree, but only at about a 70% level cooperate. And then the fourth model was you get people to agree or to cooperate at a 90% level. And it's really fascinating. So the first model, do nothing, that was bad. But the second model, do things by force, well, that was bad too. And that may not be intuitive, but that didn't work very well. The 70% agree, collaborate model got people through, they survived, but the 90% model, people thrived. Business as usual. So the key, I think, is that cultural piece of calling everybody to the higher purpose. You're serving your state. You're trying to save your neighbors. You're trying to, make your place the place that you want, the golden rule, treat others the way you want your parents treated. And by really sending this message of service and altruism and community and love for each other, and the governor's done a great job of this. He says we've all pulled the rope in the same direction, but we've not only held together, we get people now saying that, vaccine hesitancy is almost nil, at least in the world I live in, and saying, I want to get vaccinated, but I know that, these people really need it before I do, and that to me is the key. It is more cultural than it is structural.
And just a little follow-up. I really appreciate the answer. I'm sorry it's so loud. I'm outside shoveling snow. So as you were developing your plans, then it sounds like you're involved with the state business leaders, legislative leaders, pretty much all the king's horses and all the queen's men that you could get. And then you had dialogues and came out with a plan that people bought into. Is that, am I oversimplifying?
Yeah, I think that I'm sorry, I keep,
okay.
Yeah. I would say that the answer is that we have really made a plan, but really the plan was to create a structure that allowed us to adapt quickly to what we were learning and seeing. And so we were able to change quickly. one of the things that happened was that we looked at our own data and we figured out that the in-school transmission was really low. We had made a big map using incidence rate and percent positive rates for community spread to delineate whether schools could be in person or had to be virtual. And what we found was, and we work with Dr. Emily Oster at Brown University, who's done some really good work here. What we found is in-school transmission was really low. So we were able to reactivate K through 8 in-person learning after the December or January holiday. But to do that, we had placed an essential worker status on our educators over 50 years old to be vaccinated first. So we were able to pivot, and we immunized about 20,000 of our educators and service workers over 50 years old in 2 weeks to move into this. And so, we've created a plan that we are configuring around these principles that I said, save lives, maintain capacity, but it's fluid from the standpoint, the governor is the CEO of the state and works closely with legislative leaders and all that. But we have a task force that has 15 sectors represented around the table, including local health departments, hospitals, nursing homes, FEMA. We'll include Walgreens, which is our selection for the federal pharmacy activation now. And this group really moment to moment is meeting, 3 times a day, 7 days a week, and working through problems and empowering members to solve those problems as long as they meet the principles. And for us, that is shot. If it's allocated to you, it goes in somebody's arm in our priority list appropriately within 7 days. And so there is a lot of communication. We have press briefs. We meet with each other constantly. We text with each other constantly. But the foundation is the top-down part is to set, what we are committed to do. But the bottoms-up part is we invite the empowerment and the creativity of each member of our team to help make it better. And we're not afraid to try and to fail.
Thank you, Senator Rosen. And we're going to wrap up here on time, but Senator Rosen, I want your question. Oh, and Senator Nelson. Yes.
Oh, well, thank you, Madam Chair. And actually, Senator Abeler addressed it. I could go deeper into that conversation, but certainly will defer to Senator Nelson. Thank you.
Thank you, Senator Rosen. Senator Nelson. Senator Nelson, please unmute.
Oh, we are still having those technical difficulties. This one was a person error. Sorry about that. Thank you, Madam Chair. Dr. Marsh, I hope I didn't miss this, but if I did, I apologize. But one of the issues that I hear the most from my constituents is the fact of actually being able to get to where the vaccines are. And then there's also the issue of prioritization. And so we had like a first come, first serve. And then one time we had a lottery system. And I just am so concerned that we have limited supplies of the vaccines. They are increasing. That's good. But how is your state making sure that the limited supply of vaccines actually get into the arms of those who are at greatest risk first? What's the secret sauce in getting those vaccines to the people that need them most first?
Dr. Marsh?
Yes, thank you for the question. So I did go over some of our priority scheme, and I'll be happy if that can be communicated to you so I don't go back through that further. That'd be good. But I think that your point is so well taken. I was just on a call with a group of state leaders who are dealing with some of these same issues. And Atul Gawande, who's a really well-recognized physician, author, leader, he was on the call, and he said the balance between convenience and trust is really what the vaccination's made of. And I love that. I think that's really right. So we have really tried to make available vaccine in every county. So through local health departments, federally qualified health centers, group practices, larger ones, and hospital-based practices. We're really, like I said, we're trying to leverage our infrastructure rich parts of our state as much as we can. And big hospitals see a lot of our our citizens. And we have intentionally gone nursing homes first, and we finished our first and second vaccines. That was 50% of our deaths. And then we went initially over 80-year-olds, and then we went to over 70-year-olds, and the CDC came out with 65. So we're at 65 and over. But we are absolutely, we are focused like a laser beam at that population. And as I mentioned to the group, I'm so proud. And, this is like, be proud for a second, because pretty soon things change dramatically. I get that. But I'm so proud that because of the strategy of really focusing on the elder part of our population, and we haven't added pre-existing illness below 65 yet, which we will in our next phase. But we have seen about a 70% reduction in mortality over the first 5 weeks of 2021. And we've seen an almost equal reduction in hospitalizations. And we've seen the fewest number of ICU people that we have had hospitalized since November, and also with ventilators. So we believe the strategy is working. And we believe by targeting the people most likely to die, most likely to be hospitalized, it really helps us meet the goals that we have set forth, which is that sort of, mission statement that we have. So whatever you do, you go back up against what True North is, and then whatever you want to do to get there, that's cool. And then share it, because if you figured out a way to do it well, we want to spread it so that we can scale it to others.
Thank you, Dr. Marsh. And Madam Chair, just a quick follow-up. So that focused protection is so critical, and it seems to me that it's our healthcare providers that know best how to, after the congregate living settings, how best to proceed. And maybe we should follow up later, but there's been an allocation issue as well that, and I would be interested in West Virginia's allocation to our healthcare providers. A number of our hospitals are not getting the vaccines that they think they need. So I'll take that up offline, Madam Chair. I appreciate Dr. Marsh. Thank you so much.
And Dr. Marsh, I appreciate you just talking through how you made decisions, the structures you put in place so that those decisions could be rolled out effectively. As you said, everybody's doing the best they can at the time they're doing it. We're just trying to learn how we can continue to do things better. And you're on top for a good long time on vaccine distributions. I appreciate you sharing your expertise with the committee here.
Well, thank you. And thank you for all that you're doing, and anything that we can share, we're always happy to. And anything that you guys find working well, please shout out to us, because we're always also really interested in learning from everybody else.
Will do. Thank you very much, Dr. Marsh, and members, we are adjourned for the day. Thank you.